Greg Kucera, PhD, is a professor of internal medicine section on hematology and oncology at Wake Forest University School of Medicine. He is an associate in the Department of Cancer Biology, Physiology, and Pharmacology. He has over 31 years of research experience on novel therapeutics for cancer treatment. He has conducted research on over 25 RIB-approved clinical trials at Wake Forest. Dr. Kucera's laboratory has expertise in synthesizing novel therapeutics, lipid biochemistry, and in vitro drug testing. Dr. Kucera is an inventor on 5 issued patents and is an author on over 70 peer-reviewed scientific articles and book chapters. His research has been funded by the NIH, Kucera Pharmaceutical Company, and the North Carolina Biotech Center, the North Carolina Strategic Technology and Applied Research Initiative, and others. Greg is a proud member of the class of 1982 and will be moderating today's panel. Greg, turning it over to you for the introduction of our panelists.
Okay, great. Thanks, Lauren. Boy, I'm so excited about this. You know, today is the Global COVID-19 Summit, so this is highly appropriate that we're doing this today. Couldn't have picked a better date. So I'd like to introduce our panel first. I've included some description that they provided, but let's just go down the line and have each panelist give a little bit more description about their career and where they are right now. So Donna, we'll start with you.
I was a pleasantly quiet infectious disease physician, just taking care of 20 patients a day for the last 30 years until the last 2 years of my life, when I suddenly became the person everyone wanted to talk to in my neighborhood, community, church, library, school district, family, etc. So,
all right, thank you, Donna. And John, are you available?
Can y'all hear me?
Absolutely. Hey, John.
Okay. Well, am I on? I can't even see myself on.
I can see you. You're looking sharp.
You can see me, huh?
Yeah.
Okay. Well, I'm John Spangler, and of course, class of 82 with you guys. Miss seeing some of you all. And I am a family physician and professor of family medicine at Wake Forest School of Medicine, also used to be known as Bowman Gray when we were in college. I have a classic sort of academic job where I see patients, teach medical students and residents, and also do research. And my research is mainly focused on tobacco use and addictions.
Thanks, John. I remember, John, you were my physics partner at Davidson. You were so much smarter than I was. I still got the D for Davidson in physics. But anyway, Edith,
hi,
tell us a little bit about yourself.
Yes, so I'm now Dean of the College of Public Health at University of Iowa, and I came in 2010. I was previously on faculty at University of Michigan for about 15 years. And a lot of my research has been on what we call community engaged research, working with communities on issues that they have identified as important. And a lot of that's been around environmental causes of childhood diseases such as asthma, et cetera. Although I admit that I do more administration now than I do research, but so.
All right, well, we certainly have the A-team here tonight. So Donna, I want to relay a story to you that I'm good friends with our infectious disease doctor here, Chris Ohl, and I'm also a course director for the first year medical students in a course called Metabolism and Defense, which has biochemistry, immunology, microbiology, and virology included in that. And in January of 2020, he sent a message to me and the virology instructor and said, I don't know, but there's something coming out of China we got to pay attention to. And sure, by golly, we did, didn't we? So that was an early warning for that. And so let's talk about as with any class, you have to have goals and objectives, right? Everybody's taking notes, but tonight we're just going to have some fun and hopefully we'll learn something. And we're going to discuss perspectives on how COVID has changed medical practice for better or for worse. So I've got a word cloud activity here. Let's see if you can do it. You can text Greg Kucera, 409-22333, or if you're on a computer, you can go to that URL above and just think back over the past 2 years and come up with a word or a phrase that described your pandemic experience. You can post more than once if you want. And let's see if we can get anybody to get a response up there.
Greg, are we posting in the chat?
No, you're posting on your phone. And so you're texting to 22333. So just go to your phone and open up the chat or the texting app, and you can try that. Let's see if I can get it here.
Apparently the word exhausting cannot be found.
Yeah, endless years. You know, the thing that really hit me is, you know, time just, you had nothing to hang your time passage upon. You know, usually you would go to the beach or something and you could say, oh, we did that a month ago, or we went and did this or that. And it was easy to sort of keep track of time. But as we moved through that first year and into the second year, it's hard to imagine. I had a grandchild who was born in February of 2020. Luckily, we were able to see him right before everything closed down. But, you know, it was hit or miss that first year. And then once we started getting vaccinated, we were able to test and get together. But that was, time was sort of a funny notion at that point in time. All right, thanks for that. So we'll start with some panel questions here, and I've got a couple of questions that I've jotted down, and I'll give an intro to, and we'll let our panelists go through. I've got probably about 6 or 7 we'll go through, and then we'll end up with plenty of time at the end for folks to ask some questions. So the first one I'll pose to any of our 3 panelists. The pandemic has been especially hard on healthcare workers, physically, emotionally, spiritually, etc. How have you tried to change your goals and aspirations to try and improve your overall well-being? And I'll just throw that as a toss-up. Who'd like to go first?
Well, I can jump in and say that the one upside of the total pandemic is that being in isolation, I took up hiking again. And my husband and I have now set as a goal to finish hiking the Ice Age Trail by the time we're 70. So we're 1/5 of the way down so far.
Very good.
I think for me, one of the big changes was just to focus on relationships, especially family relationships, because that's really all that came over to our house were family, because, you know, obviously no one else wanted to be with you unless they knew exactly where you've been. But in focusing on relationships, I also found out that I was at work in my job with medical students and research in particular. My focus was less on accomplishments and on success, quote unquote, and more on sort of the process and of being with, again, focusing on relationships. So I seem to be, and this is sort of carried over, seem to have carried that over into my current life now, where I just don't take life quite as seriously as I did, too seriously as I did before the pandemic.
Great. Yeah, I agree. I think, you know, getting together with family was the most important thing and about the only thing we could do. And then we tried to be as protective as we could with each other. Edith, what would you like to add?
You know, I'm more, I don't do clinical care, but I think for me, it's sort of like John's. Certainly things, Donna, I hired an online personal trainer for 3 times a week, and that was a godsend personally. But I think also trying to think about our students and faculty and staff who were working remotely and really stressed out, particularly the students, and really trying to think much more purposeful about communication and, you know, emails, trying to kind of say it's going to be okay, but also sort of trying to recognize how tough it was generation. And we're seeing it, of course, with some mental health issues that are coming out of that, particularly.
Oh, absolutely.
Right.
Yeah.
I think one funny thing.
Go ahead, Donna.
One disconnect is that for those of us who are in the front lines doing clinical care, there never was really total isolation. We just were immersed and working full time. And so it's sometimes hard for us to just totally wrap our heads around how much of a downer the last 2 years was for everybody else.
Mm-hmm. Yeah, no, I agree. I think there were 2 sort of separate camps, those that the essential workers that had to be on the front lines, and those that were able to stay away from harm. And, you know,
well, I have a comment to that, actually, because since I'm outpatient only, I no longer do inpatient. I used to. Actually, my job got slower. I didn't have as much work to do, because patients weren't coming into the clinic, and some patients weren't even calling to make, you know, virtual visits. So I sort of had the opposite experience of, I'm sure, what Donna had in her inpatient experience, where things just got really slow. And in fact, in a lot of primary care practices closed. I mean, like literally went under financially because patients just weren't coming in, and that was their bread and butter.
Absolutely. Yeah. And then too, people were putting off this routine care, and they weren't getting their screenings, and now they're coming in 2 years later with massive tumors or other health issues that it could have been dealt with much easier before. So yeah, you're right. Okay, so for this next question, we've got a little lead in on that one. It says the opioid crisis and deaths related to e-cigarettes among teenagers have dominated news headlines recently. The CDC recently reported that at least 34 people have died as a result of vaping, and in 2017, opioid addiction was responsible for more than 47,000 deaths in the US. That number continues to climb. Opioid addiction has been declared a public health emergency. However, these serious public health threats seem to obscure the ever-increasing population of US citizens that are obese. It is said that obesity is second only to cigarette smoking as a leading preventable death in the United States. Nearly 1 in 5 deaths of African Americans and Caucasians aged 40 to 85 is attributed to obesity. That rate is increasing across generations. And so our question then is, how have you seen the pandemic affect public health or your patients in terms of these largely preventable illnesses? And what sort of policy decisions should we be thinking about as a society to alleviate these maladies? And so, Edith, this is a question for you. This is your public health question.
Yeah, no, I think that's a great question. And you know, you talk about the impact of this on, you know, preventive, like clinic visits, which I think that John probably can talk about and already has referred to. But we also know that if you look at the risk factors, then obesity was such a huge one for this. And so, you know, here we have this really pandemic of obesity that contributed to this pandemic, or actually a healthcare crisis when this pandemic came along. And, you know, I think that also the other aspect of this is that we saw that health disparities really contributed to, you know, adverse health outcomes. So these are 2 big public health issues that we've known have been out there and are not addressing the way we should. We also know with obesity that prevention is key, because once you are obese, you know, even if people go on diets, we're seeing that, and I'm looking at John, who probably knows the literature more than I, that we're not having much results with that. So I think that we really have to keep thinking about prevention. And, you know, my plea is that we spend 3% of our healthcare dollars on prevention in this country. And we saw it, you know, we weren't prepared for this pandemic. I've got some really scary figures of how much NIH's budget has increased, whereas CDC's is flatlined. So until we really start thinking about that, and not just sort of individual targeted campaigns, but really thinking about social determinants, access to fresh foods that are affordable, you know, sort of all of our ways that the built environment and how that impacts that until we really take a broader view, we're just not going to get there. But we see now that it's not an isolated chronic disease. It really much impacts infectious diseases. So we have to do a better job with really funding an infrastructure for public health, I think.
Absolutely. Yeah, thank you. John or Donna, do you want to chime in on that?
I would just say that I think there were so many interesting points about the interplay between obesity, inflammatory response, immunity, and the disease itself. I think, Greg, your mind must be reeling with all the possibilities with lipid metabolism going on in these studies. And, you know, I hope that some of those questions will actually perhaps unlock some of these keys down the road.
Mm-hmm. Yeah.
So I agree with everything y'all have said. I really, I have a public health at myself with a background in public health. But what I've seen sort of clinically is that a lot of my patients worsened their habits during the pandemic. I specifically remember or know of one patient whom I was caring for over 4 or 5 months on phone. She didn't have access to video, so our visits were by phone. And so I wasn't actually physically seeing her. And she was already heavy. But when I finally did see her, because she had to be admitted to the hospital, she had really put on excessive amount of weight. And it was shocking how much. And I think really she was depressed and she was lonely and she basically just went to bed and ate. Mm-hmm. Now, contrasting to that is that our group has done research we've been following college students over the last 10 years who were class of 2014 when they were in college. And we were able to follow them through the pandemic. And we actually saw that people who smoked actually smoked less, and people quit smoking more often. I don't know. I can't explain that, but maybe it's because you're stuck inside and no one wants you to smoke around them, or you're not out smoking with friends or whatever. So I think it's really depends a little bit on the habit and also on the population.
Yeah, interesting. What about vaping? Did you see an increase in vaping? I know you've done research in that as well.
We saw the same phenomenon with vaping. There was neither an increased uptake of vaping, new vapors, and there was actually a decrease in the amount of vaping. Maybe we just have an unusual cohort, but it was really kind of surprising to see. I do think that, maybe smoking and vaping are unique. I do know that I also have a fairly substantial practice in opioid addiction patients. And those patients definitely worsened their substance use disorder during the pandemic. And I think it had to do a lot with just the stress, but you would think that would also increase smokers. Mm-hmm. But opioid addiction really, I think, got out of hand during the pandemic.
Yeah, absolutely. Yeah, no question about that. So Leanne asked, did people who vape have worse outcomes? I guess worse outcomes in terms of their COVID response.
Of their COVID response?
Yes.
I don't know. I'd have to defer to Donna. I don't know that clinically.
Ironically, actually, in the hospital, smoking and COPD, while it made you slightly higher risk, it was not one of the bigger risk factors. So I would say no, not especially, unless you had really advanced COPD going into pretty bad COVID, then you were in bad shape. But I was going to circle back briefly. John, I think you touched on something that I noted a lot, and I think Edith, as we try to address these tandem epidemics, it seemed to me that loneliness, despair, hopelessness, depression, media overwhelm had a lot of interplay between obesity, substance abuse, et cetera. And solving those problems is going to require addressing some of those characteristics of our society too.
Yeah, I think the pandemic really brought out a lot of the worst in our society in so many ways. It's really kind of sad. You would have hoped that, the country to kind of come together and, approach this as a team, but that didn't happen. So much of the worst of ourselves, I think, came out in so many ways.
I saw it interesting. I was looking at, there was a study done by some folks in Great Britain, and they were suggesting that using a sort of survey that's done on countries' trust of each other, and then correlated that with COVID outcomes in terms of mortality. And the countries that had higher trust, not of government organizations, but of each other, the countries tended to do better in terms of their outcomes in COVID. Now, they didn't have the explanatory mechanism, but I thought it was pretty interesting thinking about how kind of divided we've been on some of these issues like mask wearing and vaccine mandates. And maybe that it's where people trust enough to kind of sacrifice for each other that they seem to have a better outcome. So it's kind of interesting to think about.
That is really interesting. I know I have a data set on population data in the counties of North Carolina, and looking at COVID death rates, the counties that have the highest death rates for COVID in North Carolina over the pandemic period were not the counties that had the highest smoking rates or alcohol use rates. They were the counties that had the highest rates of obesity, which of course we know is true. And also they tended to be counties where there was a high population density, which makes a lot of sense. But, I would have thought that smoking would have been more of a risk factor, as you mentioned, Donna. It's not really so much. But the other big factors for counties with high death rates had to do with minority populations, and those counties with higher rates of African American and Hispanics had much higher rates of death.
So John,
my husband just was telling me this morning that he's working on a study with some of this data, and he was surprised to say that smoothed out at the end of the epidemic, though. That was true in the early waves, but in the Delta and Omicron waves, not so much true at all. So. Yeah,
this was actually before Omicron. It was actually more in like 2021.
Which, I think would make sense if you think about the social determinants. So it's probably not only obesity, which probably is higher prevalence in some, African American, Latino populations, but also occupational exposures. For example, in our state, meatpacking workers were deemed essential. So they were right in the front line with these exposures. And I imagine that, as vaccines came and more protection, so the tail end, Donna, to your point, they may not have been as at risk as they were early on. But I think it was that dual threat of what already existing health conditions and then what other occupational exposures that they experienced. So.
Yeah, it's interesting you talked about social determinants. One of the other things that kind of popped out in the linear regression was food insecurity. Mm-hmm. And that kind of encapsulates so much so many of the social determinants of health that it's hard to know exactly what that means. But it is kind of interesting that poverty and its associated factors, at least earlier in the epidemic, were really highly associated with mortality.
Yeah. So Lex Alexander writes in the chat, related to the trust outcome and mask mandates, he read today that the percentage of COVID fatalities who were vaccinated rose from 19% last fall to 42% more recently. The writer posited that non-pharmaceutical interventions made the difference by making the vaccine have to work less hard. What are your thoughts about that? So I guess he's identifying that there were other determinants out in the environment that were taking effect, and the vaccine had to work less hard, I guess.
I would just say that's a really complex topic. We have waning immunity, variable degrees of immunity, variable degrees of natural immunity. So studying waning efficacy is really hard right now. Plus we've unmasked, plus we're congregating, plus blah, 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 blah. There are so many variables in that equation. And then the further thing is that our vaccinated population is much greater now. So we expect to see breakthroughs in more people who are vaccinated just because so many more people are vaccinated. So it's a difficult one to sluice out, but there is no question that there was, a viral burden, that decreasing the viral burden or your exposure to viral quantity decreased the severity of disease, and mask wearing did contribute to that. So, there's some plausibility to that theory for sure, Lex. And it's just really difficult to know how to ascribe the various components that go into that equation. And also, looking back, I think at some point we're likely to say, at least in our clinical experience, the Delta wave was vastly different than the other waves in terms of how many people died and what it clinically looked like. And I think at some point we may look back and say, wow, we were comparing apples to oranges and oranges to lemons and lemons to pears. And, I'm not sure how to sort this data anymore because learning on the fly has really been hard. So,
Donna, I think that's a really good point, just the differences in how infectious the later variants are. I will say that interestingly enough at Iowa, where we had no mandate, we had initially a mask mandate, but even that was rescinded. Politics have been interesting, as well as no vaccine mandate. But we saw very little classroom transmission, if any at all, that we could trace back. And I think what was happening is students and faculty were social distancing, at least in the early on, and were also wearing masks. Now, what happened after hours is where we saw this just really scary spike in August of 2020 when students came back. And so finally they kind of closed the bars, and then the cases went back down. So I think it was the after hours socializing that probably, when they took the mask off, was responsible for that. But also it was not as seemingly as infectious as some of the latest variants that came through. So I think your point's really good. It's just too complex really to know at this point.
Well, I know anecdotally, my daughter's a third grade teacher, and her school was extremely strict about social distancing and wearing masks. Of course, not all schools did that, but they had very little transmission within their school.
Yeah, I think that was sort of the rule. The schools did very well, the elementary, middle, and high schools. I think where we ran into a lot of problems, though, were in our college campuses, at least at Wake. During that initial wave, Wake Forest was really reeling from infections, and the contact tracing was very interesting. Again, my friend Chris Ohl was telling me, man, these students are getting around, seeing each other, and you can tell by who was becoming infected.
We did not have much transmission in our classrooms up until January of this year with Omicron. And we had a number of classrooms go down with Omicron. And also masks had become laxer. We still allow them, but we don't require them. So it was interesting to see how we suddenly rose in January.
Yeah. And I think as the virus mutates too, we're going to see different sequelae taking place. All right, so here's the big elephant in the room, vaccines. So vaccines are a very hot topic, especially now. We've seen vaccine hesitancy in the past related to debunked published research that continues today. Basic science continues to make outstanding progress in vaccine technology, and undoubtedly progress will continue at a pace that we've not seen before. What do we as health and healthcare professionals have to communicate to the general public related to disease prevention?
Wow.
I got nothing for you on that.
I
take my vaccines and I'm happy to have them.
I just think it's just a whole new world, you know. I've got a lot of faculty who are doing some really interesting work on vaccine hesitancy, particularly in rural areas in Iowa and throughout the Midwest. And they're shaking their heads. And these are people who are pretty darn good communication, risk perception, kind of, you know, researchers and professionals. But one thing they have said is, you know, that they feel like that the argument has, that there's all the politics that are part of this now. So this is all the public health recommendations are, you know, are much more political than we would think. And yet when you look back at the 1918, there were a lot of anti-maskers back then too. So we shouldn't have been surprised that this would come. But one thing they do say is they feel like that we haven't sort of tried to figure out always what's driving these concerns. And so the polarization has made it so that we're just telling people what to do, not sort of stopping and doing kind of a motivational interviewing. I'm looking at you, John, sort of what are the values that are driving this decision, and see if we can change that there. Not sure that would work, but I will say another plug is I think we probably need to put some, you know, we put how many trillions of dollars into vaccine production, which we should have. And gosh, we should pat ourselves on the back because what a remarkable feat that was. But we put very little money into figuring out how we were going to get the vaccines rolled out, and even less money in sort of thinking about issues like vaccine hesitancy and what the messaging would be. And we've got some really good social science and psychology researchers in this country that, given the resources, probably could kind of really begin to look at this issue more, particularly in the context of where we are with social media, that many of our strategies in the past did not have to be clapped there.
So I didn't have a lot of success with my vaccine hesitant patients. And these were patients that I've been caring for 20 years or so. We have a really close relationship. And despite that, they were, you know, well, thank you for your opinion, Dr. Spangler. But I really found that the only hope I had for success in talking to patients that were vaccine hesitant was to really listen more than talk, and really try to understand where they're coming from. And I think, Edith, you might have mentioned motivational interviewing. Did you say that? So,
I did, John.
And I use that technique a lot in my practice. But one, basically, you're trying to instigate in the patient some sort of cognitive dissonance, that they're doing something that they know they shouldn't do, and yet they're still doing it. And pointing that out to patients can be helpful. So, you know, in terms of like masks, for example, patients, you know, griping about wearing masks, they say masks don't work. And I say, well, you know, surgeons wear masks in the operating room. I wonder why they do that. And so kind of bringing out some ways to create in them a way to question their own preconceived notions or conspiracy theories or whatever.
I actually wondered a little more whether we need to go back and rethink public, two things: basic health literacy and health education classes in the grade schools and elementary schools. I know my kids said, if they saw one more picture of gonorrhea, they would barf, but they couldn't tell you what a white cell was to save their life. And I do think that people really don't understand immunity, infection, and things like that at all. And we could really use some more basic sound education in the grade school levels. But I also think, you know, when you look back on the history of public health in our country, we have made so many remarkable strides in solving problems, but we never talk about them, publicize them, market them. And so people don't even see where public health has been a benefit to them. And I agree, Edith, some of those billions of dollars we spend in developing vaccines would be well spent sort of pointing out where these things are valuable to them.
Yeah, Donna, that's a great, you know what we say in public health, our problem is if we do our job well, then you don't know we exist. And so it's really hard to kind of get funding or get people to buy in when you're doing your job well. Now, we didn't do it that well now, so maybe they're paying a little bit more attention, but yeah.
Yeah. So Denard asks, is there a reason not to get the vaccine?
Well, I can't really, I mean, I guess maybe there is somewheres. I guess if you're allergic to its components.
Yeah, I was going to say, if you had an allergic reaction to your first dose, don't get a second and third. But I can think of no reason not to get a COVID vaccine, and I can think of many reasons to get one.
I mean, yeah, I think some people don't like to hear that because there's just so much, you know, fake news or whatever, conspiracy theories or whatever about the vaccines, and they cause you to be sterile, or they, you know, they're injecting microchips into you or whatever. It's hard to break through that. And that really does, I think, lead to a lot of vaccine hesitancy. I personally don't think there's any, you know, any reason not to get vaccinated. Unless you're in a population that hasn't been approved for like, I guess it's now like, you know, under 2 or 3 years old, those patients can't be vaccinated, but otherwise I think everyone can.
Having said that, I would say, you know, I won't lie, I did not look forward to getting my vaccines. I had pretty significant reactions to several of them in terms of fever, sore lymph nodes, fatigue for a couple of days. So I'd be strategic about when you get vaccinated. You know, don't plan to host a dinner party the night you're doing it, because you may not want to. But I do think it's an investment worth making. So. And
Donna, what do you think about, so, you know, if you've been vaccinated with your 2 doses of Pfizer or Moderna or 1 dose of J&J and you get your booster, now are we in that age, in the class of 82, where we should be thinking about getting that second booster?
So I have to say, Greg, I really had such sore lymph nodes after my first booster that I really did not want to get another booster. And then I started to see this, not tidal wave, but the surge coming. And I knew that my last booster was in September, and I am in fact 62 now.
I think we're all about that age.
And so I crept out 3 weeks ago and got yet another booster. And I'm so excited to say I had 0 reaction this time. I did switch. I had been Pfizer, and there is some data to suggest that switching it up may be helpful. So if you've been a Pfizer, go with Moderna. If you've been a Moderna, think about going with Pfizer. Moderna has a little bit higher antibody level production than Pfizer, but there's some differences in how they work. So there might be value in a mix and match plan. I don't know, John, what are you telling people?
I'm sorry, did you ask me something?
I was curious what you're telling people about mix and match and
about getting boosters.
For boosters.
Yeah, I just get a lot of questions about when I should have them and should I have them? And I say, yes, you should have them. And I don't know exactly when you should have your 4th booster, but you need it. I'm really pretty big on recommending that to patients. Really, even if they have I mean, I don't know exactly what the data are, but even if patients have kind of minimal reasons to get a booster, I think they should get boosted. I mean, if they've got maybe just diabetes, or maybe they're 60 years old or whatever, I'm really encouraging patients to get vaccinated, get boosted rather than not.
Yeah, I would say if you've been vaccinated but not boosted yet, and you are in one of those zones that's moving up from, what is it? What colors are we using now? Green to yellow? You should get vaccinated this month. And if you have not, if you've had a third booster but not a fourth, it's been more than 6 months, or you should probably get the fourth now too. So.
Donna, I'd suggest maybe just having a shingle shot, and then my experience was that made the boosters look like it was a piece of work.
Let's not go here. I haven't had my shingles shot yet.
Okay, sorry, I'm
vaccine hesitant.
I don't want to make you vaccine hesitant.
That's a good point, Edith. Leanne asks on a slightly different topic, and I think this is going to jump into my next question too, but related to vaccine hesitancy, what do we know about long COVID? How will this affect medicine and public health? And I think my question was, long COVID will no doubt be with us in the future. About 29% of patients hospitalized with COVID pneumonia in the UK still have substantial impairments at 1 year. We'll be treating these patients likely for years, and they are also our family members and friends. Maybe some even maybe even some of us are experiencing long COVID. And I think, John, you sort of led off this question.
Had his heart damaged by COVID, and so I'm just I'm concerned about whether we can, you know, what we're really going to see in the future. It does look like maybe Paxlovid, the medication that's used for treatment of early COVID in someone who's at high risk, it does look like that may have some impact on long COVID. So maybe we do have something that can help with it.
I would also say I've seen plenty of anecdotal reports of boosters actually improving long COVID symptomatology or vaccination if they were not previously vaccinated. Don't know how much legitimacy there is to that yet. I think the data is still accruing, but yeah, we're thinking about for patients who are symptomatic. I'm also concerned about the data coming out. I think, wait, was it you, Edith, that does childhood disease, and the skyrocketing rates of type 1 diabetes in kids who've had COVID is also very alarming.
I wonder if it was affected the pancreas or something.
We do know that it is cytotoxic to pancreatic islet cells. And so there is concern that it may be one of the longer term consequences is a serious uptick in type 1 diabetes, particularly among younger adults.
Yeah.
So.
You know, I think that I don't have the clinical experience you have, but I think one thing that's made me nervous is I think there was a narrative, at least in our university, that, well, if it's mostly young folks who get it, they're not going to die. And, you know, it'll be like the flu and they'll move on without any thought of the possibility of something such as the impact in terms of, you know, diabetes or long COVID, et cetera. So I think we're going to be figuring out this for a while.
Absolutely. I think so. So Diane said that her daughter contracted shingles, and so she says, get your shingles vaccine. And Bernard, again, I have a close friend who had COVID on March 2020 and was on a ventilator for 3 weeks, amazed to be alive. She is participating in long COVID at a study, I guess, at long COVID. Who else is doing these studies besides Harvard? Does anybody know about any long COVID studies ongoing?
I think most, Donna, y'all, but I mean, there's one going on behind me at our hospital and healthcare system. I think probably every state, and I don't know, a lot of academic medical centers, I think this is a huge issue where they've set up clinics for this. So John, Donna.
Yeah, I don't work in a research facility, so I don't see it so much, but I do know that the medical school near us has a long COVID clinic that they're looking at. I'm sure Vanderbilt would have one in Nashville.
Yeah,
absolutely. Yeah,
okay,
most academic centers.
We've got about 5 minutes left. So is this going to work? Can I go there? Are there any other questions from the audience that we want to go through? I think I have maybe one more or two more questions, but if there are some burning questions from the audience, I'd like to take those in the last couple minutes. And if not, we'll keep on going. All right, well, I'll go on with the next question then. How do you think the government agencies could have handled the COVID pandemic situation better? And what do you see should be goals for a coordinated response to future disease outbreaks? Should the CDC be peer reviewed?
So I thought the CDC was kind of peer reviewed because, I mean, they're all colleagues and they're all very well renowned in their respective fields, and they do look over each other's work. But I guess being peer reviewed by yourself is not the same. I would hope that they're using evidence-based recommendations, and my experience actually having worked with them is that they really do try to be evidence-based. So whether it's peer reviewed or not, I mean, evidence typically is peer reviewed, but new evidence may not be quite so much. I mean, just sort of empirical evidence off the street.
If anything, I would say that the data was coming so fast and furious and was so unculled and unmanaged that their size and unwieldiness made them unable to be nimble enough to respond to it in a timely fashion. And that one other layer of peer review would just make it more awkward. What we really needed was a triumvirate of czars that would just say, we've reviewed these documents and this is what you should do this week. And we're going to change it again next week because it's still coming fast and furious. But
yeah, Donna, if any of y'all have ever published with anybody from CDC, their peer review process, it would be 10 years after the pandemic when they would have come to a conclusion. But, I think that they did make some mistakes. I think probably a lot on communication, just like not expressing the uncertainty of what was coming. And got it. So I'll stop before I turn the recording off again.
Well, I go ahead.
There was a really interesting editorial, or not editorial, but discussion. I think it was in the New England Journal a couple of weeks ago about the challenges that the CDC faced because we are a republic and every state is responsible for their own public health. So they couldn't even collect data that was consistent across state lines. I mean, the definition of what was an active case of COVID was not standardized because we have decided as a nation that states should control health decisions. And so it's difficult to know how much blame to give them when our own choices as a nation tied them from being able to formulate a national policy or accrue national data in any meaningful way. So we got what we paid for. It might not be what we wanted, but it's what we paid for.
I think.
Well, it kind of gets into a little bit of a philosophical issue for some, because, what we really need sort of like an FDA for the whole country for public health, so that, each state does not make their own decisions about whether a drug's going to be approved or not. The FDA does. And we need that for public health. But, state health departments are going to really work against that, I think, because they want local control. And there is this huge push to have states' rights or local control of different types of conditions. I think as a society, philosophically, some feel better about nationalized kinds of policies than others. And I think that's just a really tough one to break with people being so concerned about their state being able to make, or their locality being able to make their own decisions.
I would guess, Edith, would you say that the local public health infrastructure would be resistant to that, or would the local governments put pressure on the local public health infrastructure to be resistant to that?
Yeah, I think it's probably the latter. I mean, we talked about healthcare people, but boy, public health people, local ones, they've just been through hell and back, with people like threatening them. And I've got a few folks in our local who've been, people showed up at their house with guns, et cetera. So mad about it, they're pushing for a mask mandate. So much so that, I mean, they wanted to do the right thing. And there were tensions with them in the state because, they felt like they weren't getting the support and the guidance perhaps that they could. And I think that given, that they would be more, but they would probably meet some resistance with, the county supervisors, et cetera, who might have a whole different point of view on that. But I mean, I don't know, we lost so much public health workforce from the recession in 2009. And now we saw this great blip of applications into public health the first year, and then a drop. And I can't help but think that, these bright young students were like, oh, this is great. I now want to do epidemiology. And then they're like, I don't want to be a part of that. It's just too political. So I think we've really going to have to do a lot to make it more attractive to folks.
Yeah. Well, this is all great discussion. Let's see if I can get to the next. All right, so we already went through questions from the audience. So I've got another word cloud here. Type a word or phrase that gives you hope about the health policy and healthcare in the future. Nobody's, they're not popping up. I don't know what's going on with that. Didn't work this time.
I'm still trying to think of a word.
It doesn't seem to be popping up. Anyway, I hope everybody has enjoyed this, and I've sure learned a lot about that. Any closing remarks from our panelists?
Okay, let's just all get our vaccines so we can get together for our reunion.
Absolutely.
It's still surging nationwide, so we could be wiped out just yet if you're not careful. Take care.
Well, thank you all so much, Greg, Donna, Edith, and John, for taking the time to speak with us today and leading us in the conversation. I also want to extend a big thank you to the Class of 1982 Reunion Committee for sponsoring this event. Do note that this event was recorded and will be available on the website in about 2 or so weeks. Finally, thanks to all of you for joining us this evening, and I hope everyone enjoys the rest of your night. And I hope to see all of you in person in June. It was truly an absolute pleasure. I learned personally so much. So thank you. Thank you so much.
Yeah, thanks everybody. And thanks to the audience for great participation. And we'll see you soon. See you in June. Bye-bye.
Have a great one all.
Bye.
Bye-bye.
Thanks so much.